Hello everyone, how are you? Welcome to Dr. Kim's Oral Radiology channel, where we will always talk about interesting radiographic cases. All right, so today is yet another very interesting case that I'm very proud to share with you. This is a female patient in her teens, so teenage girls. What we have here is a reconstructed panoramic radiograph showing a very well corticated radiolucency in the area of tooth number 27, 28, 29. And it extends from the cervical third of the root inferiorly to just below the apex of tooth number 28. Now, like we always do, let's assess its behavior on the surrounding structure and internal density. Well, internally, it's pretty clear that it's radiolucent. We don't see any heterogeneity or mixed density type of appearance. Any root resorption? Not really. Any displacement? That's tough to tell, but I think one can argue that, yeah, there may be some, there may be an increased interdental distance between this canine and first premolar, especially when you compare that to the other side, okay? And if you look at the overall quality, excuse me, not quality, quantity of the bone and the dentition, we don't see any gross carious lesion or any bone loss. All right, so let's go ahead and take a look at the lesion in the multiplanar reconstruction view. Okay, so all the features that we saw previously, what does this is seen here, but what this multiplanar reconstruction view adds is the buccolingual appreciation of the lesion. We definitely saw the lesion, its mesiodistal extension. However, we were unable to visualize its expansion in buccolingual direction. And we see that there is a rather prominent expansion occurring toward the buccal aspect, where we can still see a thinned cortical plate, but it has not been perforated. Whereas the lingual side, it seems to have stopped right at the level of the cortical plate. Okay. And no expansion, unlike the buccal side. Now, let's look here. Again, very well corticated radiolucency. So you should start brainstorming of what this could be, right? Not much displacement, no root resorption. It's radiolucent. It's not exactly periapical, even though on panoramic radiograph, it looks as if it's arising from tooth number 28, but we see that from here that it's actually, its epicenter appears to be between 27 and 28. Whereas on panoramic radiograph, based on that alone, some of them may have included radicular cysts, but I think from this view, radicular cysts should be either out of the differential or very low in the differential diagnosis. And plus the fact that you look at this tooth, there is no evidence for gross caries, right? So if there's no caries, then you don't want to put your radicular cyst at the top of your differential. So what could this be? This actually is a very tough one based on the radiographic feature alone because of its behavior. Yeah, while it's showing some aggressive features with perhaps mild tooth displacement and the expansion of the ridge, one could consider, I think, odontogenic keratocyst. but it could also be a lot of other benign odontogenic tumor. Uh, final diagnosis, of course, is less, uh, shown in the title, which is AOT, Adenomatoid Odontogenic Tumor. But this is an especially difficult lesion to come up with a diagnosis based on the radiographic features alone, because of the classic representation, radiographic representation of odontogenic, excuse me, AOT, adenomatoid odontogenic tumor, will show internal calcification, typically involving the crown of an unerupted maxillary, say, canine. But here, all teeth are fully erupted, and internally it's completely radiolucent. So I think the ordering doctor put lateral periodontal cyst as a differential, which for this patient's age, since we're looking at teenager, uh, it's a little ill-fitting. So in the sense that lateral periodontal cyst occurs in an older patient, 40s or older, and their size tend to be usually 10 millimeters or less, although there's a variant form where it can appear multilocular and even much larger than 10 millimeter. But a classic, lateral periodontal cyst is in the premolar, it could be in the premolar region, and very well circular radiolucency, less than 10 millimeter in diameter. But I can see why the clinician may have included lateral periodontal cyst, since the tooth, I presume, is vital. But like I said, OKC could be one. There could be, again, a lot of other lesions that could be considered. But this patient being teenager, and we know that AOT occurs most commonly in young patient, like in teenager. So this is a good learning case for me to see a non-classic example of AOT. I don't know if I could have come up with that differential, quite honestly, if I only had the CBCT alone. But again, I always learn from looking at these scans, and I never stop learning. And the truth is, a lesion can behave and appear however they want, like wherever they want to appear and however they want to, uh, wherever and however they want to appear. Okay, that's what I wanted to say. So always keep that in mind, that lesions may or may not follow the classic textbook description. But I've been told that histologically, AOT is very, very definitive. Like, it's very characteristic that you see almost like a duct-like cells. And I won't go too much into that because I'm certainly not expert in that area. But it's very characteristic. However, radiographically, at least in this case, I don't see anything that's very characteristic of AOT. It's not pericoronal, but rather it's periradicular. I don't see any internal calcifications. There's no impaction whatsoever. And so, yeah, this would be a very, very tough case. So just wanted to, share this case with you again. Thank you. I hope you find this channel interesting. Please subscribe, and I will see you in the next video. Take care.